Okay. Do you
Good
want to?
afternoon.
Yeah. Sorry.
Yeah, we're going to go ahead and get started. Dr. Watts, I am going to ask you to come off of mute and maybe show your smiling face and just do a quick introduction of what we're trying to accomplish here today.
Okay, well, hi, I'm Betsy Watts. I'm a pediatrician in Northern Virginia, and am pleased to be the pediatric lead for the VMAP program. I'm collaborating with emergency physicians in a project to work together towards educating physicians across the state, ED physicians across the state, about pediatric mental health. It is part of a number 2 of a 3-part series. And we hope that you'll join us for the last one coming up. Anyways, welcome and thank you for your time. I'm really pleased to have child and adolescent psychiatrist Bella Sood with us today, and Dr. Greg Sturs as our pediatric emergency physician, who is with the HCA system in Richmond. And I'll let them tell a little bit more about themselves if they would like to, but otherwise I think we should just jump right in.
Yeah, wonderful. Thank you, Betsy. And I'm so pleased with having Greg as a co-presenter. I'm at PCU, I've been here about 35 years, and I'm absolutely delighted because it's the first time I'm interacting with emergency room docs, and I hope that the collaboration becomes stronger and we can be mutually helpful as we kind of go along, because we do know that agitation is one of those areas which is particularly distressing. I mean, say for most of us in PCP practices as well as in child psychiatry, that as soon as we get to the point of the child is getting agitated, we immediately say, send them to the ED. Well, you are the guys where the buck stops, right? You can't send them anywhere except once they stabilize. So this really becomes a very important aspect of working. And I'm really happy that this topic is something that we're going to be covering. So did you feel much more adept at managing agitation? Greg, would you like to say anything introductory while I share my screen?
Sure. My name is Greg Sturs, and I'm a pediatric acute care physician, and I work in the pediatric emergency room at Chippenham here in Richmond. I came into VMAP just because I felt like I was doing so much of this on a daily basis, and that I thought that it would be a good way to help make this mental health care better for children, and that's how I kind of fell into this.
Excellent, thank you. And it's really been good talking with you and working with you on this particular project. So we know that agitation is one of those really seriously difficult presentations as a symptom. And it really kind of creates so much of difficulty for, all around us. It disrupts care, and it really causes your staff to kind of blow their gasket, right? Because everyone is getting hurt and hit and injured, and they're looking to you for leadership and saying, do something about this. So oftentimes physical restraints, which are really sort of the pit of, healthcare. And oftentimes these can end up in really mortality. And so it becomes really, really important for us to know how to ablate aggression and how to deal with it in the here and now with the knowledge base that we will be discussing. So I guess we never learn anything until we really hear the story and actually can walk in the shoes of the ED doc who comes across, a scenario such as this. So I'm going to ask Greg, because Greg is the person who generated these stories from his clinical care. So I'll let him take this on, and he's going to introduce our 2 vignettes.
So our first case is an 8-year-old who comes into the emergency room with their mother. They have a history of ADHD, and over the last several weeks, they've been regressing at home. They've been defiant and acting out. Their behavior has escalated. They're physically attacking their younger sibling, and kicking and punching the mother. And mom says to you, I just can't keep them safe anymore. I need you to do something. So some of the behaviors the mom mostly complains about are punching, kicking. Most recently, he became very upset and punched some holes in the walls and upset some furniture. And then the last straw was that they found him setting small fires in the room, and the mom happened to come on into the room and discover them. And so she brings him into the emergency room to see you. When he gets back into the room, he's kind of hissing, spitting, and punching a tech. He's cursing at the nurse, who is known to be pretty patient, especially with kids. He won't change into a gown, and he clearly is agitated and definitely doesn't want to be there. Finally, as you're coming into the room, he's banging on the glass door and demanding to be let out. So that's the first case of a child who presents with kind of as aggression being the chief complaint. The second case is more of a progressive case, and this would be a 13-year-old who comes into the emergency room with actually a complaint of suicidality. So they told their parents that they wish they were dead. They come into the emergency room and they're pacing. They clearly don't want to be there. They have linear lacerations on their wrists and forearms. You interview the patient and are able to build a little bit of a rapport there. They acknowledge sadness, and they acknowledge that they have some suicidal ideations, and this has been going on for a while, and it's been building. They have a personal history of smoking marijuana, which the parents recently found out about, which escalated this kind of suicidality. Initially, it seems pretty straightforward. We've all seen cases like this, that this kid has suicidal thinking. Psychiatry weighs in and feels like they need to be admitted, which is pretty clear. And that's when it kind of, for lack of a better word, it hits the fan. So she throws the mother's purse. She's jumping on the bed. She's screaming. Definitely does not want to be admitted. She tries to make several runs through the door, and she's physically stopped and restrained by the mother. The nurse gets in front of the exit, and she's escalating. She's disrupting your emergency room. She's threatening staff, and as she's a big kid, so she's physically intimidating to several of the staff. And so this is kind of the patient that escalates because they don't like the way that their care has proceeded, and that they're facing an admission and really don't want that. So they're kind of escalating right in front of you in the emergency room.
And so this is the end of the shift, and you are kind of exhausted, right? Psych has not left any recommendations for you as to what to do. They've just said needs to be hospitalized, and this kid is just kind of losing it right in front of you. Medical student has just kind of, given you this EKG and said, does this look bad? And so you have all of these things sort of coming at you from all angles. Medicine has just come out and reamed you out about not doing the labs on the kid you just admitted. And so your life kind of goes from, from bad to worse as time goes on. So, and this kid is sitting there and you don't know what to do, these two kids, and your nurses are getting pretty upset. So let's take a look at these real life scenarios and see how we can approach it. And hopefully by the end of this conversation, that you will end up feeling more sort of, okay, I know what I'm doing, right? So how do we approach this to make things easy? Let's take a look at the 8-year-old. So you do know that the history here that the mother has revealed to you is that this kid has had ADHD in the past. So you're kind of wondering, is this a chronic problem? Is this been escalating over a period of time and now has suddenly blossomed in the ED? Or is it something which happened in the past week? Was he being bullied in school? Why is this suddenly kind of come to this situation versus being a chronic problem? So is it the underlying condition, the ADHD, which is driving the aggression, or is it something completely different? And is it a situation where the baseline problem has not been adequately treated by either the PCP or the child and adolescent psychiatrist? Because that stuff really is important as you think about disposition down the road. So take the 13-year-old case. This is a kid who came in and appeared sad, right? So where did the escalation of the aggression begin is when she was told that she was going to be hospitalized, and then everything was up for grabs. So is it that anxiety is leading this kid to feel so agitated. So this is the only way they can telegraph to you, I don't want to do this. And they just kind of, the aggression escalates. Or we know that the kid has been using marijuana. Is the substances kind of causing the kid to behave this way? So it really becomes important for us, the gears in our brain start thinking, what is the underlying etiology here? And what should be the aim of treatment, right? So are we kind of looking at ablating the aggression like here and now because it's so wild and bully? Or are we looking at not only thinking of the immediacy, but also thinking of the long haul? Like, are we going to put things into place which are going to work as an outpatient? Are we thinking of hospitalization? And our concerns are, is it immediate safety of the patient, of the staff, of everyone around? Or is it that we have to be thinking, okay, my mind is thinking, what do I do with this patient? How am I constructing the etiology, the framework of where the genesis of the aggression is from? And also, when I choose my medications, do I really aim for least side effects with the best impact upon the aggression, as well as considering drug-drug interaction? So do no harm, that kind of a thing. So having given you this background, what we are going to be doing today is to learn, how do we recognize agitation in ED setting? How do we kind of look at a variety of different things which causes agitation in young kids? And these could be an underlying mental health diagnosis like ADHD, anxiety, psychosis, how to recognize it. We don't want to be you to become a child psychiatrist, but at least kind of know what are sort of the major things which drive these diagnoses, as if I were looking at the case. And then we will talk about how to work with a kid non-pharmacologically in the ED, and then look at medications, and we'll be providing you with an algorithm of how to approach this. We'll look at how do we select medications for the various kinds of agitation, and how do we initiate, taper, and time our doses. So let's start with, what is agitation, right? So if a kid is really kicking and screaming, he's throwing things around, it doesn't take a rocket scientist to figure out, hey, that's agitation. So that's not what we're talking about. It's really the recognition of agitation as it's developing, because as much as we can prevent the escalation, the better it is, right? So the kid who's looking angry and kind of is snarling at you, and you're just ignoring it because you're so busy and you really did not pick up on the cue. Or the kid who's foot tapping, pacing, wringing their hands, and as they kind of are looking around, they're almost like paranoid that someone's about to get them, or they don't like where they are, and the agitation is gradually increasing till they become verbally abusive. You know, they begin to use the B word, and they're kind of, looking at their mother with murderous glances, and they just don't want to be there. And then this kind of then goes on to the projectile, which is coming at you or at the nurse. And then you have, the kid actively wanting to harm. So it's not a process which just goes from 0 to 60 in most cases. Kids give you the warning that they are escalating. And that is an important thing to observe and watch as we try to develop a framework of how we want to approach it. Now, you may think of, oh, there's Dr. Sood, she's been doing this for 30, 40 years, it's an old hat to her. How do we do it? But let me tell you, you are not the only one. If you think you're the only one who doesn't know what to do, when I began to review stuff for the ED and agitation, there's very little in the literature. In fact, there are very few randomized controlled trials, and it's usually expert opinion which drives the rationale for handling aggression in the ED. What we know as child psychiatrists and perhaps PCPs who are doing BMAP courses is that much of what we do is for the long haul, the chronic agitated kid. We know what to do with them. But as far as the ED is concerned, oftentimes, we don't know much, and we kind of use, interventions which we are most comfortable with. And that's fine, but these may not be effective. And we do want to know what are the situations which will get you into unsafe practice, and so on and so forth. So I just put the slide in to tell you that don't think that you're the only one who doesn't know, because the literature, there is not much there. hopefully we're kind of beginning to do some of more work in this area, and we'll get some more evidence-based material. Nevertheless, expert opinion is what is going to guide this discussion today, and I think it's pretty decent at this point in time. So what are the critical concepts that we should be considering when we think of managing agitation in the ED? So number one, very simple. It must be an effort which is multidisciplinary. So involving not only our role as physicians, but also our nurses, our techs who are there, parent who is in the room, anyone who knows the kid well, all of that information you're pulling together and really coming up with a collaborative plan, rather than you just being sort of this lone ranger who's going to go out and lasso in this wild pony there, right? And it has to be individualized. So specific to the kid, which is why these questions become really important, that you try to understand where the kid is. And pharmacology really is a small portion of the entire management, although when we think of agitated kids, medicines are the first thing that comes to our mind. So I want you to kind of really flip that around and think that the non-pharmacological management is really important. So an algorithm that you should be considering is that your first and foremost intention ought to be, what is driving the aggression? What is the genesis of this? Because aggression just doesn't come out of the blue. I mean, say, I'm not a very agitated or angry person, but sometimes I can get angry too. That's not something that will land me in the ED, right? But usually these things are arising from antecedents which are causing the kid to lose it. So I want to understand, where is this aggression coming from? We want to kind of put into place simple strategies that are non-pharmacological, which can calm the kid down. And then choosing medications based upon a rational approach, which is reflective of the history of mental health issues, or if it is a one-time event, what is the most pragmatic way of addressing it? So think of it as this kind of model, which is like a circular model. So if we look at the left top quadrant, we kind of see that we are looking at the cause of the aggression. For this, we should ask the parent things like, I know that your kid has been really angry, and I kind of want to get to know what this feels like. So could you describe to me, you've mentioned how aggressive he's been in the past, 4 weeks or so. Could you just describe to me what comes to your mind as 4 scenarios or 3 scenarios of from the beginning to the end, how did it escalate? What you're trying to get is, in the mom's word or the father's the voice, sort of a description of what led to the aggression, because those themes are going to marry your technical knowledge of the underlying criteria for the disorder, and you're going to come to a conclusion that this is what's going on. So as you're doing that, you're also kind of looking at how the kid is interacting with the ED environment. Are they particularly agitated because of XYZ? How can you modify that? What have the nursing staff observed? What have previous notes in the information indicated to you? So you're gathering this information from wherever you can get that to get a sense of what is happening. Your non-pharmacological interventions, the next point, which is we will kind of elaborate on in just a bit, which really is going to be very important. And what environmental changes can be put into play right there and then, or we have set the ED up in a way that it can ablate the aggression. And the last bit is deciding what medications you might want to use. And these are based upon past history, the need to ablate the aggression right away, and so on and so forth. So if the aggression does not stop, you go right back to the top left quadrant and look at the etiology again. So you're re-examining what is going on, why this is not working, and what could be possibilities that you have missed as you are gathering the history. So it's a continual process, and that's why I kind of think of it as a circular kind of thing. Before you start anything with the kid, you want to ask the mom or the caregiver as to why do you think the kid is so aggressive here, or what has been happening in the past? Is it the environment? Is it environmental issues, or are there interpersonal stuff going on? Meaning, that they can't stand their sister, or they have a really bad relationship with mom. So if she speaks, they kind of go off the deep end. Maybe some putting distance where everyone acknowledges that's a problem. For right now, we need to kind of intervene by putting them away. Is the kid in physical pain? Because sometimes when you're hurting, you can kind of become upset and aggressive. And is there a past diagnosis which you're seeing amplified? So I generally will ask questions like, is this very similar to the kind of things that bother him at home, or which, cause his, ADD to flare up, and that's what this looks like? Or is it qualitatively different? Because you're trying to find out, is that where this is coming from? Any type of substances that the person might have been used, like the 13-year-old, you wonder whether she had some PCP-laced marijuana, which is kind of showing its face now. So agitation can definitely be there. You definitely want to ask about trauma. Sometimes an adolescent or even a younger child may have been sexually assaulted and will not tell the parent. And so it's coming out as this great distress, which then blossoms into this behavior within the ED. So trauma is an often unrecognized thing that we must ask about. Now you're thinking, oh my God, there's so many of these things, but it can be a focused type of an interview which gets at these major principles. So let's start off with the non-pharmacological management. What are considerations that you must give? So you, as I said, always must think of this as a way of de-escalating existing aggression or stopping it from starting up. So I consider this from a public health perspective, like a primary, secondary, and a tertiary prevention model. So the primary prevention techniques is that as a baseline, your team needs to be thinking of how can we make our emergency room more comfortable for children, right? So make it more kiddie friendly. And Greg suggested some of this. What he does in his ED is reduction of bright lights, because that can make kids much more reactive to what's going on. Availability of things. Obviously, you don't want to use the devices as a way of, projectile that they're going to throw at you. But if they're calm, these can de-escalate the kid because they feel more, at their baseline what they're comfortable with. So having parents bring back things which are soothing to the child, encourage that, as long as the agitation is not in the severe variety where that can be utilized as a projectile. Make your communications and the entire team's communication very clear, with the idea of reducing anxiety. So even the tone of our voice and the way we approach these kids, not being judgmental, for example, because whenever you see a badly acting kid, you immediately think, oh, he's spoiled, or he's a brat, or she is blah, blah, blah. So we have these labels, but think of yourself as an observing person who's looking at, why is this kid so agitated, and why are they telegraphing their sense of anxiety and distress by getting so agitated? So you want to reduce it. So you have to kind of really understand that agitation is a means of asking for help. How can you help them in a way that that doesn't become the default mechanism of getting the help? So then we think of secondary prevention, which is that you are recognizing that a kid is at risk. They've had a history of acting out as per the parents, or you're seeing that they're kind of moving from the mild to the moderate to the severe, and you need to keep a keen eye of awareness for that. So you turn to the parent and ask, what has worked in the past? What do you feel has really helped? Because it may be very counterintuitive, right? So it is hard to leave a child who's telling me, leave me alone, but sometimes that may be pretty effective, right? So you're observing them, but you're putting distance, and you're not barraging them with questions. So that becomes very important, to listen with a third ear. What is the kid asking of you? Putting the kid into a safe, calm area, so that if there's a lot of noise going on in the corridor, and typically I would expect an ED, bunches of stuff is happening. So how do you keep them in a calm environment? And you should sort of consider that as a change in the way you kind of develop your environment within the ED as a long-term process. Communicating in an empathetic tone. Some of us have it naturally in us that we're very calm, we're calmness producing. Some of us tend to be aggressive and abrasive because we're in a quick, do it now environment. And that can be perceived by the child as being abrasive. You can get the same stuff done, but do it in a way where the kid is seeing you as an empathetic adult and where you're communicating in an empathetic tone, but which is neutral, non-judgmental. And for that, you have to do your own processing of how you view aggression and be able to give clear, concise, developmentally appropriate language, which is understandable to the child. So all of these things really help the kid de-escalate and see you as sort of their friend. So tips and tricks that may be helpful here is that definitely with developmentally disabled children, you want to be equipping the ED with tools that can keep them calm and know that they are probably going to be slower in their responses. And so change the way you go about your expectations of them. Sometimes removal of kids from that parent who they are viewing as toxic in that moment might be helpful. And sometimes having the parent as a support system. So be asking of that, what would be helpful? Getting them food, drink, making sure that there are things that they consider helpful for them, which are part of their daily existence, and getting that fluffy toy or for the young child or things that makes them comfortable. It is very important for you to be able to set firm limits on unacceptable behavior, but praise kids when they're doing something good. So if they're able to follow directions, praise that hugely, because that positive reinforcement goes a long way. Try not to be judgmental, because when we do that, then we are, when we think of research, two-tailed hypothesis versus one sort of assumption that that's where this is going to go, we sometimes miss a great deal of data. So it leads to poor decision making. So you really have to step back and say, agitation is simply the symptoms like fever, right? You've got to figure out what's leading to it, and I'm going to get to the bottom of it. I'm going to be the best detective that I can be. And understand that this is the best they can do at that point. So that is an important concept, which is called collaborative problem solving. We don't want them to come to us. We want to go to them and then drag them like this to a better place. And you're going to be part and parcel of it. What that does is it models effective parenting for situations where the parenting is one of the causes for the aggression, where the parent just is a poor match for the kid. So when you're able to show that, it's good. Making reflective statements, how difficult must this be for you? Let us both kind of figure out what is going to be helpful for you. This gives you a lot of information because the kid is being pulled in as a partner and can tell you what is going on. So those are some of the non-pharm approaches. And now let's look at, when do we use medications? So we want to target the underlying cause. So if there's a diagnosis, we want to make sure that that is ablated or is treated, and that the kid is sufficiently calm so that they can get involved in helping you with the assessment as well as the treatment. Have to understand that the meds we use in the emergency room are really temporary. It's for here and now. And that if we use them, then that should be with the assumption that eventually, for particularly antipsychotics, should be kind of reduced and tapered off after a certain point. And document that plan, because when we are forced to document how we're going to approach this, it really clarifies in our mind what seems muddy and gray and why are we doing what we're doing. Now, always remember that no one medication will be appropriate. And this goes to the fact that agitation has a multifactorial etiology. So obviously, one medication is not going to be effective. If the kid has a previous history of being on meds, get a full history, reconciliation, how compliant they have been on it or versus not. What PRNs have worked in the past, and sometimes just giving that dose of the medication which they have missed and is causing the aggression can be very helpful. Or 1.5 times the dosing of that can ablate the aggression because that's been helpful. PO is preferred over IM, but if you have an IV on running, then that is a very good place to version of PRNs to use through the IV line. Use neuroleptics judiciously, partly because they have side effects and they can cause extrapyramidal side effects, oculogyric crisis, those kinds of things. So you got to be very careful. And the general rule of thumb regarding PRNs is the following. This is really kind of a very critical concept. That is that you want to know underlying conditions which really prevent you from using things like benzodiazepines. And these are possibility of delirium. And we'll talk about delirium in just a bit. Withdrawal or intoxication from substances, where the child has had his history of paradoxical disinhibition. For example, me, if I take Valium or if I take any diazepam, I'm just kind of gone. I have a terrible time. Even Benadryl causes me to have restless legs. So I make sure that everyone and their brother know that I react like that. So if you have a history of that, or developmentally disabled children, who can get very sedated, and that's when the danger stuff comes. Greg tells me that that period after the person is over the agitation and is sedated and can be where death can occur as a result of the fact that you are not cognizant of how these can impact. If those are not the cases, then using antihistaminics, benzodiazepines and alpha-2 agonists are good for symptomatic calming down of the kid. And when the diagnosis is unknown, or it's a younger child, mild agitation, these interventions are pretty on point. Mild to moderate severe anxiety, which is not due to delirium, intoxication, withdrawal. So those are the golden words in my mind. If you really want to make sure this kid is not delirious, because things like lorazepam or other benzos can really cause dysregulation and paradoxical disinhibition. So let's take a look at aggression. And we're not talking about tantrums. Tantrums are that spoiled child who can't get their way and just has learned how to manage their parents and adults around them by having it their way. And when they don't get it, that's when it kind of gets awful. But I'm going to share with you the way a child psychiatrist thinks about agitation related to mental health disorders. I'm going to share this with you, and I don't want you to gasp, but as you can see, impulsivity and aggression arises from a myriad of things. And it's, to me, agitation is almost like what you would consider like a fever. So when we look at, for example, a person complaining of chest pain, what do? We get a very good history. This is an adult, so getting a history of past MIs, any recent stressors, risk factors like smoking, alcohol use. We do a physical examination, observe for jugular vein distension. We look at how short of breath the person is. We listen to the hearts, we listen to the lungs, and you know exactly what to do, how to work up. Although the person presented with a chest pain, right? So the chest pain is, to me, like the agitation piece of it. But because you know enough of this stuff, you know how to systematically approach an MI or a pulmonary embolism, because that's the workup. So similarly, we are going to kind of talk about irritability, which is a great masquerader, because there are tons of things in psychiatry which can lead to this irritability. So when you have, for example, a physical thing like chest pain, it could be very many things. It could just be like a muscle ache or whatever. It could be an MI. Shortness of breath can be several things. Asthma, it could be a PE, cough, it could be congestive heart failure at the worst portion, or it could be simply an upper respiratory tract infection. So I'm going to share with you that, irritable mood can be part of major depression. It can be part of ADHD because it comes from the impulsivity that these kids have. Oppositional kids can get agitated because whenever someone in authority says something to them, they're going to, the sky is blue, no, it's purple. Anxiety can lead to irritability because they don't want to do what you're asking them to do, and they're very anxious about it, so they'll come out of it like a cornered cat. DMDD is known for the irritable mood in the child, which remains chronically there in the background. Mania, you see episodic aggression, but that is accompanied by very many other things. In autism, these kids are not always have mental health problems, but they can have, anxiety. They could have paranoia. They could have many things which lead to agitation-looking stuff. Executive function deficits are those which are related to ADHD, where the kid has a learning disability of kind, feels like a square peg in a round hole, just feels very uncomfortable with the learning environment, etc., and really goes off the deep end. I have a kid yesterday who I did a crisis intervention for, who was exactly this, that her ADHD and her LD was really acting up. And she then began to make statements about self-harm because she felt so unsuccessful in the school. So you have to do some focused questions which get you to each of these. So I'm just giving you sort of a list of the things that can masquerade as irritability, which is why your job is so hard, right? Which is why we're kind of breaking it into these topics. So I'm going to share with you a beautiful slide which will allow you to think in terms of where is this aggression coming from? So impulsive aggression is the type where a thought comes to the person's mind, like, for example, I want this, and I want it now. And if you're not going to give it to me, then I'm going to have a hissy fit. All of us have that desire sometimes, right? I want that dress, or I want to go there. And generally, we kind of put things into perspective and say, here, I can't have it because I don't have that money. And be able to take perspective and stop our id from progressing further. With the impulsive person, there's no way to filter that out. So they get agitated, and it is that child who is told no where they lose it completely. And that's where the aggression comes out. Typically seen with kids who have ADHD. So you will ask the parent, and the parent will tell you that everything was going along fine, he was happy, till I told him that you can't go to the party because your grandma is sick, we've got to go and visit grandma. And that's when stuff just escalates. And then they're not able to control the limbic system, and it just takes on. But it's important to know the nidus. The genesis of the aggression becomes very easy to get if you ask the mother to paint the scenarios of each time the kid got aggressive. So that's impulsive aggression. Affective aggression is where the parent will describe the child as moody all the time. They are either sad, they're irritable, they're angry. Unlike the hyperactive kid who can be happy between the episodes. So these are the stormy, hot kids, the DMDD kids, who the parent will describe as like walking on eggshells to live with them, because you never know when the anger is going to get out of control. So that is the second variety of aggression, which with a few focused questions you can get at. Anxious, these are the kids who have a history of anxiety. They're like worrywarts. They're kind of always worried about something or the other. They're quiet. They are usually model students. They are perfectly well behaved. But when you ask them to do something like, when they have a social phobia or they have performance anxiety, and you ask them to do those things like be with people or be around people, that's when they explode, because that's the only way of maintaining status quo. So that's the anxious aggression. The fourth is the cognitive or disorganized aggression, which can come with schizophrenia, or it can come with mild paranoia, where they are worried about the environment. They are actually very suspicious of stuff. So they're misperceiving the reality of the situation and go off the deep end when they feel as if someone is out to get them, or someone is about to, do something bad to them. And that's where it is poor reality testing, which may not meet criteria for schizophrenia, but these are just paranoid kids. Interventions for each of these, why this becomes important is that for the first one, you'll be thinking of stimulants and meds for ADD. The affective, you would be thinking of SSRIs and mood stabilizers like antipsychotics. The anxious kid is going to respond to SSRIs, right? And the cognitively disorganized kid is going to do better with neuroleptics. So that's why the etiology, how you are constructing the way you're thinking of the agitation, becomes important, because your interventions are going to be derived from that. So let's take a look at our case one. So here's a kid who has been, and so this, I'm changing the scenario a little bit. I'm making him calm. So this is the kid, the mother has brought him. He's just had a hellish experience in the past 24 hours. That school's kicked him out because he punched a teacher in the nose, and he's here in your ED. And now he's sitting there quiet on the bed, sitting calmly, playing with a Rubik's Cube. What do you do? Right? So the questions that you want to kind of, obviously you don't need to do anything terrific in the ED because the kid is calm. That's why the mother brought him. The questions you are looking at is, because this is what you're going to put in your disposition. What about outpatient care? What meds have been used? Are they enough? Are they adequately treated? Is the child going to the PCP to get their medications adjusted? Has the ADHD treatment been optimized? Is there any other comorbidity which are going on? So you're making recommendations to the outpatient provider. Your work is done. You discharge the patient, and that's great. So you get sometimes faced with these scenarios where it completely is changed, what the kid came in. And then the second scenario where the kid is agitated and it's blossoming into really worsening of the behavior. So at that point, you are now thinking of anything that I do with the ADHD piece of it is probably not going to go anywhere, except if I use alpha-2 agonists, maybe, which can be calming down, like clonidine or something like that, or diphenhydramine. That is my dog who has decided to bomb this session. And what are you kind of observing there? What are the triggers? So you want to put non-pharmacological interventions into play. We're going to be discussing the algorithm. That's what you're going to be using. And so you're changing sort of the way you are approaching the same kid in the different ways they are presenting. Let's take a look at case 2. So this is that depressed kid who is suicidal and became agitated once they were told, when child psychiatry said, you need to be hospitalized because they're worried about the risk factors, right? So you pick up on this and you say, this is beyond just the depression. It is really that this kid is anxious. And are they anxious about being hospitalized? And obviously, we know the history of the marijuana. So you want to find out when was the last time they smoked a joint. And have they ever had bad trips before? What has happened before? And is that factoring into poorly perceived reality? So if you're kind of feeling, hey, this is marijuana type of stuff, then the intervention is going to be different versus if it's anxiety. And you would get away with using something like an antihistaminic. You could get away with benzodiazepines. But if you're concerned about any delirium type of related stuff with the use of the marijuana, you want to move in a different direction. So here is a reduction of anxiety, which becomes really important, and helping sitting down with the kid and saying why the child psychiatrist felt you need to go into hospital, and helping them understand it's a short-term thing and so on and so forth. So sometimes it feels like, oh my God, I just don't have the time to do this. But if you had some, kind of a quick way of actually practicing in front of the mirror at home, that if I'm faced with this, what would I say, which would feel comfortable to the child, and really develop sort of a 5-line kind of a thing of how would you calm such a kid down. And we could do it today, but we don't have the time to do it. But you want to be thinking in terms of how do I reduce the anxiety in such a kid. So now that we have talked a lot about stuff, let's move into the phenomenology of aggression. And what are quick questions to ask if you suspect ADHD? So, quick and dirty. ADHD, the 3 cardinal symptoms are attention span problems, distractibility, impulsivity, and hyperactivity. So hyperactivity, impulsivity, and inattention are the 3 things that you see. And generally, these kids come in with the diagnosis. You're not making the diagnosis. And generally, the aggression is because of impulsivity. Like when the kid is told no, that's when they go crazy. And if that is what's causing the focused kind of problem in the setting, and you're able to establish that, it's poorly treated ADHD here. What do you do with mood disorders? These are this broad rubric which contains things like major depression. You may have heard of disruptive mood dysregulation disorder, which is DMDD for short. These kids, they start very early in life, get chronically kind of moody, and generally have neurovegetative symptoms of depression, such as not sleeping, appetite is poor, and the parent will describe these kids having subsyndromal aggression in the background, which is whenever there is a triggering anything minor, like the sister looked at them wrong, off the deep end. So they're just looking for something to kind of react to. It's looking for a reason to react. And these kids are generally those where the siblings tiptoe around them, where the whole entire family changes their structure, or what they do as a routine on the holidays or whatever, because Johnny won't like it. And this is very different from plain depression because plain depression may not have irritability per se, but DMDD does. It's a very, very important portion of it. Self-injurious behavior might be there, but generally not externalized aggression with these kids, but sometimes they can be pretty aggressive. This out of my entire population is the most prone to hit me rather than, the depressed kid. So that's what you do with mood. When this paranoia or cognitive distortions, we all know the rare as hen's teeth type of phenomena of childhood schizophrenia is literally, you don't see a whole bunch. Usually you see that in mid-adolescence, late adolescence, where you have the full-blown delusional hallucinations along with the disintegration of the kid's personality. Those are, you don't need a rocket scientist to figure that one out. You know that. But the ones that really create some difficulty is that are the ones which have this mild distortion in reality and thinking. And generally, the kind of questions you might want to ask them is, what makes you upset and angry? Do you think someone or people are trying to get at you? Does your mind play tricks on you? Do you see things or hear things which are not there? And usually auditory hallucinations are common. When you see visual hallucinations, you generally are thinking of something organic going on, and you definitely want to look at that aspect of it. Do your thoughts seem confused to you, like words that don't make sense? And that is sort of the prodrome of something like psychosis. But generally, we will be covering this in the next session, which is in November, is the second week of November, that you will be hearing about psychosis. So you'll get plenty of it. And so your job becomes to see, is that what's driving the aggression? And the last one that I'll cover is anxiety. So these are the kids, as I said, they will get a history of the parent describing the child's predominant mood. The statement that I'll always use this with kids is, how would you describe your mood? That's my cardinal question. And from that emerges where I'm going to go next. Are you generally described as happy? Will describe yourself as happy, sad, angry, or worried? And generally, kids will pick something out of that, which will tell you the prevailing mood. So the hyperactive kid will say, I'm a happy kid. The kid who tends to is moody will either choose anger or sadness. And the anxious kid will tell you that they are always anxious. And then you can go into asking them questions about what worries you, what bothers you, what might have happened here that caused you to be so upset, and what happened in the hospital in the past which makes you so upset. Is there post-traumatic stress disorder? So generally, this is when they are asked to do something that they don't want to, and they are petrified of it. There's a phobia to something, and they're pushed. So they come out of that thing like clawing their way out like a cornered cat. So it's counterintuitive to think that the anxious person would be aggressive, but that's where this comes from. So just understand where it's coming from. So the art of management, statements that can be said to the kid, which really brings them into a partnership mode, as well as gets you to, be at the same level as they are. This must be so hard for you. I'm sure you kind of really hate this, right? I don't think you like to be in the ED, because ED is not a place where you have access to your devices. You don't, can't meet your friends. You can't watch television that you want to. All your freedom sort of gets away. So how do we figure out a way that we can kind of get you out of this place as quickly as possible? So you kind of really getting them to kind of agree that they're going to participate in calming themselves down. And they're going to be a big part of helping themselves. I want you to feel better. I want you and all of us to feel safe, right? Can you tell us what might calm you down or could be helpful? So again, they may not give you anything, but you have really invited them into that partnership. So this sort of these are some of the statements that I find very helpful when I see a very difficult thing. So when a kid kind of, for example, in my session tells me, I'm not talking to you. And I said, I don't get into a fight about, you're not going to talk to me. I try to understand, this must be really hard for you. You have something going on that you're kind of busy with, and maybe we can get this done quickly so you can leave. Or I'll ask them, you look angry. I kind of just go with the affect. You look angry. And usually that makes the person stop and think and say, this person gets me. They're kind of understanding where I'm coming from. So I think that we've talked about the environmentally safe place where you do a quick assessment, awareness of triggers, removal of irritants. These are the modifiable factors. And we need to be very self-reflective in seeing what we might be adding, like the noise in the hallway. That is certainly something, like, for example, when I'm talking to a child and there's a whole bunch of noise going on, I'll just stop. And I'll let the adults calm down. Then I say, and I always tell them, this is respectful to your child. And I really want a quiet place where I can talk to them. So use tone that is empathetic and non-judgmental, yet firm. So you're not going to let them ruin your ED just because you want to be this nice doc, but you want to be firm, just as you would be as a parent, and make sure, you know, that you are the boss, but you are inviting them to participate in the thing. So now it's not getting any better. So now the pharmacological interventions for the mild, generally non-sedating PO medications. So one of the things that when Greg and I were talking about this, we feel is really important to emphasize is that you want to use calming medications, but non-sedating. Because when the kid gets zonked out, they can no longer participate, they cannot tell you what's happening inside their body, and that can be very, very dangerous. So just remember, as much as non-sedating you can get, although you want this kid to be out of it fully and not be speaking, you want to make sure that they're calm, but available to converse. In the moderate, you want to escalate to a non-sedating PO med and offer iron medications. And in the severe, both PO and iron available, and offer choices of an antipsychotic, benzodiazepine, and an antihistaminic. And then if things don't get better, you want to keep reassessing and making sure there's no delirium underneath and the person is not in a state where the medication can compound side effects. So if the diagnosis is clear, so we've talked about the phenomenology, all of those 4 categories which kind of work. Conduct disorder I didn't talk about because it's a very small population of this world which has true conduct or sociopathic tendencies, but we generally lump them into the paranoia psychotic because antipsychotics will work well with that. So if we understand what the diagnosis is, what is the underlying things that are happening, we want to use the same medications that have worked in the past, along with some of the algorithmic approach of ablating the immediate aggression. So if this does not work, we use the algorithm of mild, moderate, and severe aggression and proceed with them. And I promise you, we're getting there very soon. If the diagnosis is unclear, where you just don't have an idea of where this is coming from, or it is completely messed up, it's kind of all over the place, you are always thinking of the etiology, but you just can't arrive at that decision point. At that point, we will go with this algorithm, and I have to acknowledge my colleague at BTCC, Sandy Mitchell, who is a pediatric psychopharmacologist who has been kind enough to produce this algorithm that Greg is going to lead you as your colleague in showing you how to work through this. So let's move to the algorithm. Greg?
So this is the general kind of pathway for managing aggressions, and you can see that it's broken up into severities. So basically, level 1 is they're agitated, they're mildly aggressive, that you see increasing anxiety or verbal aggression. 2 is they're clearly demonstrating agitated behaviors. They're pacing, they're yelling, they're disruptive. You're seeing increasing increasing in severity. And then finally, level 3 is where they're an imminent threat to themselves and others and staff members. So for level 1, we would generally think of first line oral medicines, hydroxyzine, diphenhydramine are 2 ones that I tend to go with. If I'm suspicious that this is originating from more of an ADHD, I will use some clonidine to help ablate the aggressive behaviors. I'll even go, if it's kind of level 2 and they're agitated, I will use olanzapines. The ODT seems to be pretty effective for helping reduce that. And then clearly level 3 is when they're in imminent danger to themselves. You really have to do IM olanzapine, IM Haldol, IM haloperidol, or chlorpromazine, that type of stuff, and really to ablate the aggression, become get control of the safety, and really keep that kid safe. So that's kind of the general approach to the levels of the aggression, and how you would think about managing that level of aggression. So here are here's that kind of that chart kind of in a more list type of form. So mild aggression, the oral medicines that I would think of would be diphenhydramine, Benadryl, hydroxyzine. I use these pretty regularly, and children are familiar with them. They'll ask for hydroxyzine. I'm starting to feel anxious. Can I have some hydroxyzine? Absolutely. I do use benzos. I try to use them pretty sparingly. That no child has a benzodiazepine deficiency, and it really doesn't fix a whole lot. It just kind of temporizes. And I also want to plug again, especially for children with autism spectrum disorder. The benzos just lead to a disinhibited autistic child, so they're not great choices. I will use them in the older kids who are really presenting with a lot of anxiety, and that's what's driving them. I use antipsychotics pretty regularly, and I do. There's a question, and do I ever use guanfacine or clonidine? Absolutely, yeah, both of those. I tend to not do a lot of stimulants, especially working a lot of nights. But we'll get them back on their stimulant medicine, so we can use an extra dose of the guanfacine or an extra dose of the clonidine. Antipsychotics are used pretty regularly. I like risperidone as a PO medicine, and that can diminish some of the aggression. And I think I've talked about some olanzapine. The olanzapine ODT is really one of my favorite go-to medicines, and then haloperidol orally, as well as IM, which we're going to talk about here in a minute. You do have to be careful that all of these medicines have side effects, sedation. With the antihistamines, you get a paradoxical disinhibition, and almost all of these drugs that we're going to talk about will prolong the QTC. So it's important to be aware of that as you're looking at what they're on. With the antipsychotics, there's always that risk of the extrapyramidal syndrome. So I almost always combine them with antihistamines.
Dr. Sturz and Dr. Sue, let me just interrupt for one question, because 1 second, because we did have a question come in. It says, ever use guanfacine or clonidine? So I don't know if you all can address that.
Yeah, I mentioned that in there. I'll use both of those for particularly for the impulsive child whose aggression is really related to that. So I'll add an extra dose or a dose and a half of the guanfacine, especially the clonidine. That seems to work pretty well, and can help kids sleep in a busy emergency room too. So level 2, they're moderate agitation, they're increasing amount of danger. Again, you can do the POIM Benadryl, that does seem to work. Again, the lorazepam. At this point, I'm pretty much going to something that's a little more potent, the olanzapine ODT, even offering IM olanzapine or IM Haldol, that type of stuff. So this is basically the same slide as before. However, level 3, IM olanzapine. Be careful with IM olanzapine. You cannot combine it with any benzodiazepine, or these children will be at risk for respiratory depression, cardiovascular depression, and death. So just that's something that I see other providers will give, especially after handoff, that they were given olanzapine, it didn't quite do the trick. So then the next provider wants to add, some lorazepam, and so that can be pretty difficult. So I'm, for these level 3s, I'm doing olanzapine. You can combine that with some Benadryl, haloperidol IM. So that I typically will combine haloperidol with Benadryl. You can even combine it with a benzo if you're really, if the child is in imminent danger to themselves or your staff. One thing that I did want to talk about is I pretty frequently will use Geodon or I'm blanking on the on the trade name of it right now.
The
But I will,
Brazodone. Mhm.
yeah, thank you. It's the Brazodone. So I will pretty frequently use that in the emergency room. Just it's important to know that that's one of the, you know, the child psychiatrists don't like that because it really will prolong your QTC and it limits what they can use for more of a chronic thing. But it is pretty effective in ablating aggression pretty quickly. So that's kind of, you know, I'm at a, you know, psychiatric referral hospital, and so we tend to do a lot of that. So that's been a really effective tool in my arsenal as well. Anything to add, Dr. Sood?
No, I think that that's a good summary. I'm going to attribute this to Sandy Mitchell, who has created this, and we will make this available to all, because I think having the cheat sheet can be very helpful. Particularly, some of this algorithm is really a good one because it kind of tells you where you can give combination of 2, 3 for the severe aggression, because sometimes you're really lost. And this particular one also tells you the timing in between when you can repeat the dose and onset a duration of action. So as you become more comfortable, because you have this information with you and get more and more used to it, I think you'll become very good at following a certain route that kind of gets you the best effects without sedating the kid or really putting them in harm's way. So now once the patient is calm and stable, the next step is that can they be discharged home or should they be hospitalized? And that you all are pretty good at in figuring it out. And what should you base this on is obviously the stability, the parent's ability to take them back home versus feeling uncomfortable with it, and the use of the TDO if there's an indecision and you're really strongly feeling they need to be hospitalized. So the ECO, you know, those kinds of routes can be very helpful. And involving the child and parent, really, I feel right from the get-go can produce a very good outcome. So discharge planning should involve not only what you have done there, but really connecting and handing off to the primary care physician with information regarding what occurred in the ED and any suggestions that you might have. I think an important part of also this is that if you have been able to figure out and formulate what's gone on and what's caused the aggression, psychoeducation of the parent and child goes a long ways so that they can look at signs and signals which are warning in nature and what can be done to prevent them from happening, because you don't want them to be coming back. So anything to prevent recidivism, connecting them with outpatient providers and making sure they have enough meds to last them till their next appointment. And also, if it is possible at all, to get them to connect with the therapist and providers. I've added the care navigation function of VMAP as a way of navigating resources once the person leaves. This is kind of a useful thing to look at, that what are the pros, what are the barriers to really actually doing all of these things that I have talked about. And those are your environmental issues, like having an overcrowded work setting, short encounter time frame. How can we utilize those short encounters by focused questioning, which comes from the knowledge that perhaps the seminar has given you or what you've read about it. And then, obviously, there are insurance issues, etc. So the reason why all this is important is that if we think about it in a rational way, we can come up with strategies of what are the modifiable factors that we can modify so that people land in a good place. So in summary, you can really acquire the skill to stop agitation from escalating. Always be thinking of the etiology which is driving the aggression, because that's where the gold lies. Non-farm interventions must be stressed. These are background things that you can all do to your EDs. And you can ablate agitation by knowing what are safe techniques with minimally sedating medications to aim and address the etiology. Well, the post-discharge recommendation protocol that is guided by best practice guidelines, and the team could come up with what is that format. I'm sure Most EDs have that. I just don't know your environment. And so if that is not there, that would be a good thing to invest in as you go along, which can be, individualized set of recommendations. And with this, I'm going to stop sharing. I know we have gone above our time, but ready for questions. So you're on mute.
Yep. If there are no questions, a couple of housekeeping things. First of all, thank you for staying on till the end of the presentation, Dr. Sturs and Dr. Sue. That was a really, I learned things. And so that was a really excellent presentation. Thank you so much. The presentation will be posted in a couple of days on our website. I will also send it out once we have it in a format to be sent out. Please also look out in your email for your CME questions. Once I get those back, VCU will directly send you the information to obtain your CME. That is all we have for you today. If you haven't yet signed up, please register for the third and final in our series, which will address pediatric psychosis. And that is going to be on November the 15th. That is a Wednesday. I believe I got the date right, but that is a Wednesday. That one is not on a Friday. So please be aware of that. The last one will be on Wednesday, November the 15th at noon. Thank you so much and have a great day.
I do also want to make a plug.
Yes.
Our study has been finally IRB approved, and I would love to have a conversation with ED docs about the impact of the pandemic on children's mental health. And we'll be doing those interviews anywhere into the spring of next year. So if anyone is willing to participate in it, we would love to have you do that. So we'll let you know how to contact us.
Right. Thank you very much. That's all we have for you today.